It's a conversation that nearly every veteran has. You're sitting there, a guy walks over, sits down, you hear his knee crack and pop, and he laughs and says, "Man, my knees are shot, trash. I can barely do the stairs anymore." You respond, "Yeah, I did like only 4 years and mine are shot too. I can barely do squats anymore without pain." And then you both laugh, pull out your phones, and continue to scroll while you wait to meet with your doctor or your physical therapist. But what gets me is the age of these people. Most of the time when I'm in the clinic, I'm seeing men aged 30, possibly early 40s, that are saying, quote, "It's over. My knees are shot. I'm done. I just need a little bit of help to go up and down the stairs. I've given up on everything else." But here's the thing. Bad knees are not inevitable. Yes, our military service is hard on our knees. Yes, we accumulate damage. But knee pain is mostly treatable unless you have something extremely serious. Function can be restored in most cases, which we'll get into here in a moment. You don't have to accept limping around for the next 40 years of your life and avoiding stairs. Today, we're delving into the veteran knee, why the knees hurt, what's actually wrong, how I assess it, and most importantly, how I fixed it in myself and ways that in physical therapy, these different knee issues can be treated. I'm Dr. Hint. This is Mission Ready Body, and let's get into it. Let's start with the anatomy. Your knee is a hinge joint. It's designed primarily to flex, that means to bend, and to extend, which is to straighten. But it also has a small amount of rotation, even though that's not its main function. Now, the knee is formed by three bones: the femur, the tibia, and the patella, which I have pictured here. The femur is, of course, the thigh bone, the tibia, the shin bone, and the patella is the kneecap. Don't worry if you're watching about that PCL. I asked AI to generate this and decided to throw on random labels that are not useful. But these are the three bones that make up the knee. One of the things you're going to hear me talk about later is patellofemoral pain syndrome. Patello, the kneecap, femoral, the femur, knee pain. Basically, whenever you hear somebody saying, "I'm going to diagnose you or anybody else with patellofemoral pain syndrome," they're basically saying you have knee pain in the kneecap and the femur, right? It's a generalized term. Now, let's get into some of the soft tissue. For the soft tissue, you have some key structures. The menisci are one of the most important things. These are two C-shaped pieces of cartilage on the medial, that's the inside, and the lateral parts of the knee. They're called the medial and the lateral meniscus. Whenever you hear somebody say a meniscus tear, this is what they're talking about. They're pieces of cartilage that act as shock absorbers between your femur and your tibia. So they help with compressive force, and they also help deepen the knee joint. You also have four main ligaments that help stabilize the knee. The ACL, which is the anterior cruciate ligament, that helps prevent the forward sliding of the tibia. So whenever you hear somebody tore their ACL, it's usually because they have a planted leg and the tibia kept going forward and it ruptured this ligament. The PCL, the posterior cruciate ligament, it helps preventing sliding backward, hence the name posterior. The medial collateral ligament, that prevents the knee from bending inward, and then the LCL, which prevents the knee from bending outward. And by bending inward and outward, I mean being bent inward or being bent outward, like that. Now, there's also cartilage, which is the smooth tissue that covers the ends of bones, which helps them glide smoothly. And before you go off and say, cartilage, that's probably replaceable and blah, 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 it is not. Most of the time, cartilage does not come back. And even if you get a knee replacement, for example, the best plastics and lubricants they have in the world are still not as effective as your cartilage. The patellar tendon, that connects your kneecap to your shin bone. This helps transmit force from the quadricep muscles. And basically, that's kind of everything you need to know anatomically to get going. Now, why is this so important? It's so important because say that you are someone who, is treating a special forces soldier as I was, and you ask them where their knee pain hurts, and they say, well, the knee, obviously. And you ask them to point, and they point at the kneecap. And you say, okay, so it hurts in the kneecap? And they say, no, it hurts underneath the kneecap. And you say, oh, so it just hurts underneath the kneecap. It doesn't hurt in the knee joint. And they say, what's the knee joint? Again, this is not a joke. This happened to be somebody I grew up with. Like it's inside the knee joints, in between the two bones. And they say, oh, yeah, no, no, it hurts deep inside the knee bone. The knee bone, the knee joint. Oh, yeah, no, it's not even the knee joint. Just knowing anatomy like this makes your conversation with physical therapists so much easier. But let's move on before I get too engrossed in the story. It's important for us to understand that the knee is what we call a victim joint. I don't like using the term victim too much, but it is in a sense that it lives in between the hip and the ankle and it has nowhere to hide. If there's an issue going on the hip or an issue going on the ankle, whether it's tightness, whether it's restricted range of motion, whether it's weakness, it's going to be the knee that usually has to try and make up the difference to prevent injury, to try to provide stability as much as it can. So if your hips, for example, are weak or immobile, the knee is going to compensate for that lack of stability and control by trying to provide, say, for example, degrees of rotation. And that's one of the ways you can have meniscus injuries by that rotation in the knee. If your ankles are stiff or weak, well, now your body's going to make up for that lack of mobility. And this is one of the biggest issues why people have a problem squatting and lunging deep is because their ankle is stiff. And again, it's the knee trying to make up the difference. As the knee gets caught in the middle, it takes the stress of both that it was never designed to handle. And one of the most common patterns that I see is tight hip flexors, weak glutes, and stiff ankles, which are immediately going to be knee pain. So how do you undo it? You make the ankles unstiff, you strengthen the glutes, and you stretch those hip flexors and you strengthen them. This is the most common veteran complaint that I see when people come in with knee pain. It really just takes a lot of stretching and strengthening. It's one of the reasons why I assess the hips and the ankle. And in my opinion, if you're going and seeing a physical therapist and they are not assessing your hip and they are not assessing your ankle and they're only looking at the knee, they're missing 2/3 of the puzzle. And I would highly recommend that you encourage them to take a look at your hip and your ankle and say, hey, I think these could be playing a role. And for us as veterans specifically, combat boots, rucking, prolonged sitting, all these are things that are going to cause issues for us that can cause stiffness in the joints and can lead to that mobility and decrease in strength. So a lot of times when we're talking about how to treat knee pain, it's not just treating the knee, it's also treating the entire lower extremity chain. So let's talk about how military service damages the knees. The real question is, how does it not damage the knees? With rucking, it's going to impact it. Running, jumping, high impact, like jumping off of obstacles down to the ground, any sort of FTX or training exercise. If you're going to mountain school and you're doing rappelling, there's 1,001 ways. Going from sitting in a vehicle into contact, or footwear, muscle imbalances, acute injuries. There are endless reasons why the knee is going to be accumulating damage throughout this time. And we could really go into depth in each of these, but I don't think it's extremely necessary because if you've lived them, you know them. But the result from all these things is by the time that you get out, the menisci, for example, have accumulated micro tears and degeneration. The cartilage is being worn out. The knee is going to be, if you're unlucky, chronically inflamed due to weakness and tightness and or injury. There's muscle imbalances like I talked about, tight hip flexors, those weak glutes and those stiff ankles, poor movement patterns like squatting, lunging, deadlifting that no one ever actually corrected you on. They just told you to do it because you need to do it for the PT test or for whatever PT event that you're doing. And then, like I said earlier, any injuries that you've had that were never fully healed. And then one day after you get out, you decide to go for a run, climb some stairs, squat to pick something up. And then your knee says, nope, I'm done. This has now become painful. That tends to be the vast majority of veterans' knee story. So let's get into the types of knee issues. The most common type of knee pain is called patellofemoral pain syndrome, like I described earlier. It's also known as the runner's knee. And this is any pain around or behind the kneecap. What it feels like most of the time, these are generalities when I say this, does not mean it's exact. And these are, keep in mind, this is not medical advice. This is educational. This is what they teach in schools. This is what I learned in physical therapy school. This is what you will learn if you did any sort of training class online about what is patellofemoral pain syndrome. It feels like dull, aching pain around or behind the kneecap. It is worse with squatting, worse with kneeling, and worse with stairs, especially when going down the stairs. Pain after sitting with the knees bent for a prolonged period of time. And it has a little bit of grinding or clicking sensation. What typically causes it is tight and weak quads. Weak glutes and hip stabilizers, that would be your hip internal and external rotators. A tight IT band because of a weak and tight TFL, tensor fasciae latae, weak and tight hamstrings or calves, and then poor patellar movement. A lot of this is driven because of overuse from running or squatting or lunging. And with physical therapy, this has the best prognosis. Anything that is tight or anything that is weak, physical therapy excels at going in at mobilizing and strengthening. This again is the number one thing that I see in veterans. And once the physical therapist goes in and evaluates where what's weak and what's tight is tight, they develop a personalized plan to say, okay, let's stretch what's tight and strengthen what's weak. Next, patellar tendinitis, also known as jumper's knee. What does it feel like? It feels like pain at the front of the knee, just below the kneecap. It's a sharp pain that comes with jumping, running, or squatting. That would also include going from sitting to standing. Tenderness when you touch the patellar tendon, again, remembering that it's below the kneecap, and worse with explosive movements like cutting, jumping, twisting, all those sorts of things. What causes it is repetitive jumping and high impact activities, overuse from running and training, and weak quads and poor landing mechanics. A lot of the time, this is due to up chain effects. So if the patellar tendon is painful, a lot of times it has to do with a tight and weak quad, but it's also going to usually be due to weak hip issues. And a lot of time, it's also due to stiff ankles as well, just because the foot is not able to accept force the way that it should. And a lot of that force goes up the chain into the knee. And again, just like patellofemoral pain syndrome, this tends to have a really good prognosis, but it can be stubborn and take a longer time because it really takes a skilled physical therapist to go through why your jumping mechanics might be wrong, why your squatting mechanics may be wrong, and how you could be overloading that patellar tendon, either due to weakness, immobility, or just, again, poor mechanics. Maybe you have a longer femur than other people they've seen, and you have to learn to modify how you're doing a squat or a lunge. A lot of the times, too, this is one that requires what's called eccentric strengthening and load management because tendons and ligaments love eccentric loading. That is loading while it's being lengthened. And the point of, or the way that you eccentrically load is using a lower weight with either a hold time, or you would do, for example, if you're doing knee extensions, you would kick the knee nice and straight on the leg extension machine for 1 second and then control the descent of the weight for 3 seconds. So a 1-to-3 ratio. With a lower weight, with increased time, letting the knee bend and letting that tendon get lengthened. That tends to be how physical therapists in the clinic, one of the ways, would load eccentrically. IT band syndrome. If I had $1 for every time I heard this and it wasn't this, I would be slightly richer than I am now. Maybe in the order of a few $100s. The IT band is a thick band of tissue that runs from the outside of your hip all the way down to the outside of your knee. And when it gets tight and irritated, it causes pain. However, the IT band is not contractile. That means it is not a muscle. That means it does not shorten. It does not lengthen. Not like muscle. Instead, it is all attached to a muscle called the TFL, the tensor fasciae latae. That is a muscle that gets tight. That is a muscle that gets weak. And that is a muscle that most people miss when they're trying to do soft tissue on themselves, like a foam roller or anything. Most people don't even know how to stretch the TFL. You can check it out on the YouTube or the Rumble, and you can find the video. If you type in it right now on my channel, TFL stretch, you will see it. It's a very important stretch. What does IT band syndrome feel like? It feels like a sharp pain on the outside of the knee or up into the hip. It's worse with running, especially downhill. Pain typically comes on with specific distance or time, for example, like 2 to 3 miles into a run, and it's tenderness on the outside of the knee. What causes it? Weak hip abductors. This would be the TFL, this would be the glute medius, and also a tight IT band with the tensor fasciae latae, and an overuse from running on slanted surfaces. Typically, what's happening is the TFL is trying to do extra work, and in trying to do extra work, gets overworked, then it gets weak because it's been strained, then it tightens down, then it pulls from the IT band. The IT band only has one place to pull from, and that's the knee. And all this could be fixed if people did more lateral movements, such as side planks, resisted sidestepping, single leg RDLs, and things like that. So the prognosis for this is pretty good with physical therapy. It basically requires hip strengthening and IT band mobility work, mostly stretching of the TFL, in my experience, as well as some soft tissue mobilization and trigger point release of the TFL. A lot of the times, too, with that one, which I'm going to touch on here in a minute, a lot of times veterans are coming in with multiple of these. They're not coming in with just one. They're coming in with a combination of IT band and, say, patellar tendonitis or patellofemoral pain syndrome. A lot of times it's more than one thing, and the physical therapist, like me, might not be the best at communicating that. They might just kind of word salad at you and say, hey, you have weakness here, 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 and tightness here, 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 here. So here's the way we're going forward. And they might not use the label, hey, this is IT band issues, or this is a patellofemoral pain syndrome. They might just say you have a weak and tight quad and a weak and tight hip flexor or hip abductor or anything like that. And that's one of the things that you could stop and say, hey, wait a minute, I understand that I have these things, but is it like IT band issue? Is it like patellofemoral pain? Because again, depending on where the physical therapist is at in their day or their mindset or just the type of physical therapist they are, they might just be reading you the laundry list of the issues that you have and not putting it into terms that say your doctor has referred you to them to see. So they might say, hey, yeah, you have a weak hip abductor and a really tight and weak TFL. That's basically them saying you have an IT band issue. And your doctor may have referred you to them because of an IT band issue. But to you, it sounds like French because you don't understand if that's related or not. Don't be afraid to ask and say, okay, but is that like IT band stuff while I'm here? And you can have that conversation. It's something I think I need to do better. But a lot of my patients are really good at calling me out and saying, okay, but I'm here for this. Is this like this? And I go, oh, well, yes, it's very similar. Anyway, on to meniscus tears. The menisci, which are the shock absorbers that we were talking about, these can be torn from acute injury or from gradual degeneration. An acute tear means that it happens and you usually have what's called a mechanism of injury, such as you're twisting or pivoting through the knee and it pops and you usually swells up and it gives. And then you have several days of where it's not going to move because it is so swollen and painful. A degenerative tear is one that usually comes from gradual breakdown from years of wear and tear. And for example, this is from a lot of veterans that like to play basketball. What does it feel like? Pain in the joint line, either on the inside or the outside of the knee, because that's where you have that medial or lateral meniscus. Swelling, cracking, locking, or catching sensation. Difficulty fully strengthening or fully bending the knee at maximum end range. And then sometimes, like I said, a pop at the time of injury. What causes it is usually twisting or pivoting through an injury or those degenerative years of rucking, jumping, airborne, squatting, doing whatever manual labor we're required to do when we're in. The prognosis for this varies, and it's very important that you talk to an orthopedic surgeon, for example, or a DO, and say, hey, you know, I think I have a meniscus tear. My knee was been swollen for 2 or 3 days. There's a loud pop, etc. A lot of times they're going to want to go in there and do MRI, not X-ray, because X-ray is not going to be as good at seeing the meniscus. And they're going to want to see if there was a tear, what type of tear, as there are several different types of tears, how big it is, if it's flipped over and inverted, all sorts of things. And they're going to tell you what they think your prognosis is and if physical therapy would be right for you, or if they think it'd be surgery and then possibly physical therapy. The craziest thing I've seen with meniscus tears is actually a meniscus transplant. And that took over a year. That took over a year of physical therapy after they have a transplant to get them back to doing hopping, for example. So when it says, when I say variable, it varies widely. I have had friends that had meniscus tears that chose not to go to PT because they're stubborn and they know who they are because they're listening to this. And they tore one meniscus in one knee and a meniscus in the other knee, and they iced the knees. They did not go to physical therapy. They did go and get imaging, and they got told it wasn't bad enough to require surgery, so they tried to rehab it themselves while they were working for a mail carrier service. Now they have a little bit of issues with running and stuff, but they chose not to do PT. But as active as they are, they knew that cardio and running wasn't going to be something they want to get back to doing. So for them, they didn't think surgery was right. But that's a conversation that has to be had between you and your doctor. There are, especially in the military, a lot of people that get meniscus surgeries. And there's a whole bunch of different surgeries to talk about. But again, That's important for you to have your conversation with an ortho specialist or with a doctor of osteopathic medicine. Just know that PT, if you're being referred to a physical therapist, they're going to do their best to focus on mobility and strengthening, just as they would with almost any other issue. Next, osteoarthritis, also known as arthritis. Welcome to being over the age of 30. This is the breakdown of the cartilage in the knee joint and usually behind the kneecap, leading to bone-on-bone contact. What does it feel like? Stiffness, especially in the morning for the first 30 minutes. Stiffness after sitting for a prolonged period of time. Aching pain that's worse with activity, but also paradoxically sometimes gets better with activity. Swelling after activity, grinding or sound of crepitus, which is like cracking and popping with movement and a limited range of motion because of pain. What causes it? Age. It is age. Previous injuries can make it worse, and years of high impact can definitely make it worse. This is one that physical therapy doesn't fix. It doesn't heal, but a lot of the times people's arthritis are made worse with, you guessed it, tight and weak muscles, because the tighter your muscle is, the more pressure is going into the knee. Once you stretch and improve the mobility of all those muscles and then you strengthen them, it's much less force going into the knee. One of the most common types of arthritis that I see in the clinic is arthritis behind the kneecap. And when that happens, any sort of tightness of the quad pulling that kneecap down into the joint, the tibiofemoral joint, makes the pain worse. So going in there and stretching the quads and making sure that they're a nice happy length and they're also strong prevents excess grinding, which tends to drive down the pain to much better levels. But this is also one that is very variable between different severities of arthritis. One of the things that's also very common for this that you'll see is people will get what's called a corticosteroid injection into the knee when the arthritis gets this bad. And that can help sometimes or hurt sometimes. But that's a conversation to be had with a doctor. Ligamentous injuries. Oh boy, these, if you watch sports, you know about just about all these. I'm going to cover the most common two because I don't want to dive into all four because the PCL tears are very rare. Not very rare, but they're more rare. ACLs are most common, and MCLs are pretty common. LCLs are a little bit less. So ligaments can be sprained or torn from acute trauma, as we just saw with Lindsey Vonn, for example, when she was doing, I think it was her downhill skiing. The MCL being torn is the medial collateral ligament. That's on the inside of the knee. This is one of the most common ligamentous injuries. It's usually from a blow to the outside of the knee or twisting to the knee. Now, why is it a blow to the outside of the knee? Because as that force is hitting the outside of the knee, it pushes the inside of the knee apart. And as it pushes the inside of the knee apart, this ligament is trying its best to hold that knee together in close approximation, and it tears. This leads to pain and tenderness on the inside of the knee, a feeling of instability or feeling like it's going to give out when doing any sort of like squats or lunges or getting up from a seated position. These, remember from a previous podcast that I've done on sprains versus strains. When this is sprained, there's grade 1, grade 2, grade 3. Grade 1 is anything less than like a 25% tear. Grade 2 is a 25% to a near tear, and then grade 3 is a full tear. That's why when someone says, I only have a grade 2 tear, it's not grade 3, it's not fully torn. That means it could be 95% torn, right? So this is where it's important to talk to the doctor who's doing the imaging, who says, yes, you have a grade 2 tear. Cool, how much are we talking here? Would be a very important question to ask. ACL, that's the anterior cruciate ligament. This is the one that everybody in basketball tears. This is usually from sudden stopping, pivoting, or landing awkwardly. It's a pop, usually at the time of the injury. Very rapid swelling, keeping the knee from moving, and instability and difficulty walking because that tibia now wants to shift forward. This is also what that same skier, whose name now escapes me, tore. And then she decided to continue competing. So the prognosis for this, minor sprains of the MCL tend to respond very well to physical therapy. Complete tears often require surgery, especially if a person's wanting to return to athletic levels of activity. So this is one where, again, it's talking to the DO, talking to the ortho, talking to the surgeon, and saying what is right for me based on what I want to get back to. And that's very important for you as a veteran or just as a human being to know what you want to get back to. Because if you don't clearly articulate to a surgeon or an ortho or a DO what you want to get back to, they might assume that you are a couch potato and you have no ambitions of ever setting foot on the court or the court or the field or the pitch or any of those things ever again. And they're going to just assume that again that you're an average human being that never wants to run again. So why would you require special surgery? So definitely advocate for yourself and explain what your desired end state is when it comes to sprains, strains, and tears. Bursitis is an interesting one. It's an inflammation of the bursa. These are fluid-filled sacs that are around the knee, and there are several of them. There's the prepatellar bursa that's right in front of the kneecap. This often gets swollen from lots of prolonged kneeling. You see it, and at least I see it a lot in older people that do a lot of gardening or camera work. Actually, a lot of like wildlife photographers. The pes and serine bursitis is pain on the inside of the knee just below the knee joint. And this just feels like swelling, warmth, tenderness, and pain with pressure or movement. Because this is designed, the bursa are designed to decrease friction, usually around ligaments and tendons. And when they become inflamed and swollen, any movement feels uncomfortable because there's a lot of pressure on them. And the tendon or the soft tissue that they're trying to protect is usually a little bit aggravated too. This is another type of knee issue that typically responds very well to physical therapy. Especially once the underlying issue is addressed, which is usually, again, not surprisingly, tightness or weakness of a whole host of muscles that we've already talked about. So, real quick, how to tell, this is my guide. Again, this is not medical advice. This is what the questions that I ask myself in order to see what sort of pain I might be having. If I'm having pain behind my kneecap that's worse with stairs and squatting, I'm thinking patellofemoral pain syndrome. That means I usually have tightness and weakness, and then I go on the hunt to assess myself to find it. Pain just below my kneecap that's worse with jumping or pivoting or or running downstairs or running upstairs, I'm thinking patellar tendonitis. Pain on the outside of my knee that's worse with running, and I kind of notice I'm having maybe balance and stability issues. I'm starting to think IT band because my lateral hips are weak. Pain in a joint line with locking, catching, or snapping, I'm suddenly scared that I have a meniscus tear or injury. And that's when I'm starting to think, hey, I should go talk to my doctor and say, hey, I think I may have done something to my meniscus, especially if it swelled up and I couldn't move it for a couple of days. Stiffness and grinding that's worse with activity, I usually chalk that to arthritis, especially if it feels better after the first 30 minutes of the day. If I had any sort of acute injury with instability, like I was playing soccer and got slide tackled, or I was playing, I don't know, flag football, and I went to make a move and I felt my knee shift some sort of way, and now I have a lot of instability and I thought I heard a pop, I would be thinking ligamentous injury, especially if I have any swelling. I'm thinking I should go and talk to a doctor and say, hey, I have some issues. Swelling and tenderness that's worse with kneeling, for example, I'm immediately thinking bursitis. Self-assessment, how do I self-assess? Well, you're going to have to go to Patreon to see that. There are a whole host of things that I do to self-assess, and I'm just going to put that on Patreon because that's where it belongs. This is my shameless plug to get you to go there to check it out. And the link is in the description. But the big things that if I had, I would immediately go and talk to a doctor would be any significant swelling that doesn't improve in 48 hours. And one of the things you can do is you can measure this with like a sewing kit. You can take one of those seamstress measuring tapes, wrap it around your knee, measure it, and say, okay, this one is this many centimeters and this one is that many centimeters. I have a this many centimeter difference 2 or 3 hours after this happened, and you can keep track of to see if the swelling goes down or not. If I can't bear any weight through my knee, I'm going to the doctor immediately. If I have a locking or severe catching, locking is in, I can't move my knee even if I want to because the joint feels like it's locked in place. Or as I go to move it, there's like a whole catch, like it gives really quick and then I catch it or a really loud crack and pop and then it moves. I'm going to see the doctor. Any acute injury with immediate severe pain and swelling, I'm running and I go to pivot and it's pop. It's like, oh, okay, that really hurts. Like we're talking like above a 7 out of 10 pain, above a 6 out of 10 pain, and it immediately starts swelling. I'm going to the doctor. If my knee just keeps giving out repeatedly, I don't really know why, like going up or down stairs or just walking over level surfaces, I'm going to the doctor. That could be a sign of something possibly neurologic going on. And any visible deformity where like my knee is swelling up really bad in one specific area, like the pes and serine or the prepatellar versa, I would go and talk to the doctor and say, hey, I don't know what's going on. My knee should not be swelling up like this. These are all kind of common sense things. But to me, these are the red flags that I would immediately go and talk to a doctor. So now let's talk about in physical therapy, the treatment framework, which I've hinted at a little bit. 4 pillars of knee treatment. Improve mobility. I know here it says ankle mobility, but the truth is I improve mobility across the board, ankle, hip, and knee. I go after it all. If I don't have good mobility, I I I don't progress to strengthening or complex movements. Once I have good mobility, then I focus on more complex strengthening. So ankle mobility and hip mobility. Then I move into hip, ankle, and knee strengthening that's appropriate for the range of motion that I have until I have full range of motion. Then after that, once my hips are really strong and my ankles are really strong, I really zero in on the knee and try to build it up to the same level of strength that I have in my left. This is one of the reasons why I do so many single leg events. If you guys want, follow me on Heavy description. I'll put my link in the description, and you can see how many single leg events that I do. It's nearly all of them. Everything that I can do single leg, I almost do because I want to balance one leg versus the other. I want to prevent any sort of imbalances and pathologies. And so that's again one of the things I'm doing in the late term of strengthening my knees is I'm doing crazy knee strengthening, but I'm focusing on single leg stuff. And then movement re-education, I'm making sure that when I'm doing squats, lunges, etc., that I am doing it with good form, not shifting weight away from one knee onto the other, making sure my one knee isn't coming further from the other, which would be a sign to me of ankle tightness and so on and so forth. So examples of this would be like for ankle mobility, I'd be doing calf stretch. I would be doing ankle mobilizing stuff. So I'd be doing like a 3-way ankle. I could be doing ankle circles, soleus stretch, toe yoga. For my hip, I could be doing hip flexor stretch, hamstring stretch, adductor stretch, TFL stretch for sure. And just making sure all my mobility is good. Then I move into hip and ankle strengthening. So like I said, ankle calf raises. I could be doing clamshells, reverse clamshells, side plank, sideline hip abduction, single leg glute bridges, monster walks, single leg RDLs for sure, single leg, just about anything, marching with a band as well. All these are things that I'd be looking at doing to strengthen my hips. And then when I get to knee strengthening, it's going to be all about single leg knee extensions, Spanish squats, single leg pistol squats, step ups, and then eccentric quad strengthening, things like that. And then, of course, like I said, with the re-education, making sure my running form looks good, my landing looks good when I'm doing box jumps, and any sort of single leg balance discrepancies. I'm making sure I can stand on one leg for 30 seconds on both sides at least. So then when I put it all together, what I'm looking at is 2 times a week, I'm really focusing on strengthening. And then maybe 2 to 3 times a week, I'm focusing on mobility and stretching and doing like some sort of yoga for like 10 minutes per day, just making sure I keep things from getting tight. But for a progression timeline, if I hypothetically injured my knee, what I would be focusing on for the first, say, 2 weeks would be focusing on my mobility and hip strengthening and ankle strengthening. I wouldn't push through any pain, but I would just be focusing on strengthening my hip. Focusing on stretching my hip and my ankle, trying to get my full mobility back and just doing what I can do with no pain. Weeks 3 through 4, as my mobility starts reaching what is equal to my non-involved side, that's when I really zero in on my hip strength. I finish off my hip strengthening, my ankle strengthening. I start zeroing in on my knee strengthening, and I'm hoping that as my hip gets stronger, I start noticing a lot more stability. By weeks 5 and 6, I'm going from simple knee strengthening to focusing on doing more complex things like lunges, any sort of variation of that, eccentric strengthening, Spanish squats, all of that. Weeks 7 through 8, now I'm focusing on making sure my movement patterns and my plyometrics are good. And then weeks 9 through 12, I'm hoping that I've done all that well enough that I'm getting back to the things I want to do with graded exposure. That would be for something like patellofemoral pain syndrome, tendinopathy, which would be the bursitis, the patellar tendonitis, and possibly bursitis. That would all be a best case scenario with 0 complications, 0 setbacks, all the free time in the whole world, I'd be hoping by the end of 8 weeks, my strengthening is done. I'm starting to work my plyometrics, and then I'm trying to work back into getting back to what I want to do. In a perfect world, this would not include things like a meniscus repair or a ligamentous repair or anything like that, because then that you'd be talking about months. So that's the down and dirty of how I've treated my own patellofemoral pain syndrome and my own tendonitis, tendinopathy in my knee. That's kind of the progression that I followed. Within 8 to 12 weeks, almost every time that I have an issue, I'm able to get it to. I'm able to fix it pretty quick because I just go I go after the underlying issues of lack of range of motion and strength. Then after that, what I do is, if say for example the pain was so bad that I wasn't running and I want to get back to running, that's when I would look up a return to run protocol and I would start following that to dose myself back into running. So the idea would be to manage load and not do too much too soon, which would cause a flare up. And anytime that would have any pain, I would stop and I would modify. So in that vein, what about running? Is running appropriate when you have these things? It depends. If you have patellofemoral pain syndrome, if you have weakness, IT bands, osteoarthritis, for most of these, you have these issues because of underlying tightness and weakness. And it's way more important to address those things, to knock them out, to have a strong and mobile lower extremity, and then get back to running, in my opinion, than just go back into running and to try to continue to do it, because a lot of times you're feeding into those negative patterns that I was talking about, those neurological patterns, those movement patterns that you have to unlearn. So I tend to focus a lot with my patients on this is not every case, but a lot of cases, if it's really, really bad, I pause running, strengthen everything, build everything back up, and then say, okay, now we're going to focus on running with good mechanics. But it depends, right? If you're an endurance runner, if you're a marathon runner, and you're getting ready to run in a week or two, you just have that patellofemoral pain syndrome because that quad's just getting so tight and it's not strong enough, but you're still able to run 20 miles. That might call for a different approach. If it's like, okay, I'm just going to go really heavy on manual to try and reduce the pain and try to help someone power through until I can that can rest, and then we can really go after any sort of like quad knees. Sometimes, and this is not always, but sometimes you just have someone who comes into the clinic and they really only have one issue, and it's tightness. But it's the asymmetry of one side compared to the other that leads to the issues that they're having in that knee. It's rarer than most things, but it's also common enough that you see it. And usually after they learn how to stretch and strengthen that one area, they're good to go. And again, these are more your extreme athletes that like run marathons multiple times a year. So it depends. Going and seeing a physical therapist is the right answer if you're wanting to continue to run, if you have these issues, because they're going to be able to tell you based on their clinical judgment and experience what's right for you. Because the big takeaway here is you don't want to be doing more damage. So what are some good running substitutes, though, in my opinion? Cycling, swimming, elliptical, and rowing. Rucking on soft surfaces actually is lower impact than running, which I did not know. But it is one of the reasons why I do rucking now, because rucking on a soft surface feels better to me on my knees, and there's actually evidence coming out saying it's better than running for knee pain. I hate rowing with a passion, but I'm getting better at it. And it's because I hate it that I do it so much. I find the elliptical very boring, but it is a useful tool. Swimming, I would drown, so I don't do it that much, but swimming is great because there's zero impact on the knee. And cycling is great. My legs go numb, so I don't like it that much. So remember that your knees have carried you through a lot. Ruck marches, deployments, and training, they've taken a beating, but pain doesn't need to be a permanent reality for most of us. With the right approach, focusing on ankle and hip mobility, ankle and hip strengthening, then knee strengthening, and movement reeducation, which is done under this skill and guidance of a physical therapist, you can significantly reduce or eliminate your pain and get back to the activities that you love. And this is usually done for a lot of people, again, under the care of a physical therapist, but it requires constant, at least 2 to 3 times a week for 8 weeks before most people see progress. Now, next week, we're going to be diving into the mental game of physical recovery, addressing the intersection of physical and mental health, chronic pain, PTSD, and movement as medicine. If this episode helped you, please leave a like, a comment, a share to at least one other person that you know. And don't forget to check out the website. Check out 10,000 for 15% off their clothes. Check out Patreon again for some of the self assessment tools that I have. And also, don't forget to check me out on Heavy so I can show you guys some of the single leg loading stuff that I do. So remember, chances are your knees aren't broken. They just need the right TLC and support from the joints above and below. Stay mission ready, everybody. And I will catch you guys all in the next episode.